So this chapter, we are going to be reviewing heart failure. So what is heart failure? Heart failure is anything that interferes with the mechanisms regulating cardiac output. It's an abnormal pumping or filling of the heart. So either we have a problem where the blood cannot exit the heart because maybe we have a failing left ventricle that cannot pump the blood, or the filling problem would be due to really stiff ventricles. They're unable to relax and therefore unable to fill properly, affecting our cardiac output. Obviously, this results in a decrease of blood and oxygen to the tissues. So that's where some of our symptoms will progress from. On the next slide, we'll go over some primary risk factors. But this slide breaks it into primary causes and precipitating causes. You don't need to differentiate between the two, but there's really several different reasons why somebody could have heart failure. So our primary cause is conditions that directly damage the heart. So for example, coronary artery disease, hypertension, myocardial infarctions, valve disorders. Whereas precipitating causes are causes that increase the workload of the ventricles. So some of those would be infection, anemia, right? Hyper or hypovolemia, because your ventricle's having to work harder. Pulmonary embolism, that works the right side of the heart more. So there's several different reasons. It doesn't necessarily have to, you don't have to have direct damage to the heart to wind up in heart failure. Heart failure is classified as either systolic or diastolic. Sometimes you can have both, or left-sided versus right-sided heart failure, again, and you can also have both of those too. Our two primary risk factors are hypertension and coronary artery disease. The majority of patients who have heart failure have both of these. There's also contributing factors such as advanced age. We just don't work that well when we get older, right? Diabetes, tobacco use, obesity, and high serum cholesterol. And if you think about it, many of those in the contributing factors also lead to hypertension and coronary artery disease. So they kind of, all work together. So when we're looking at left-sided versus right-sided heart failure, left-sided heart failure is the most common. Why? Because the left side has our big left ventricle that's responsible for pumping blood out to the rest of our tissues. Usually has more of a workload. Also, those contributing factors such as hypertension would affect our left side much more than our right side. Blood backs up if my left ventricle is not pumping correctly. Blood backs up from my left ventricle to my right atrium, and then I wind up with fluid volume overload in my lungs. So I wind up with pulmonary edema and pulmonary congestion. A good way to remember that left-sided heart failure affects the lungs is because they both start with L. So left-sided heart failure, you will have pulmonary symptoms, left lungs. And then our right-sided heart failure. So clearly this is from right ventricular dysfunction. Blood backs up from the right ventricle into the right atrium, and therefore fluid backs up into our systemic circulation or our venous circulation. So we wind up with jugular venous distension or JVD, right? And we assess for JVD by ensuring patients are at least 45 degrees. You can't assess for JVD if somebody is laying flat. They need to be sitting up at least 45 degrees. You'd have them turn their head to the side a little bit, and then if they had JVD, it's pretty obvious that there's a vein bulging out of the side of their neck, and that would be JVD. Also fluid congestion in our liver, spleen, even in our GI tract or GI system, which can lead to bloating, constipation, and then of course our peripheral edema, which mainly we see in ankles, feet, calves, those sorts of areas. Right-sided heart failure is actually most commonly caused by left-sided heart failure. Right-sided heart failure can also be caused from pulmonary conditions. So if my right ventricle is having to work really hard to push blood into my lungs, that right ventricle is going to wind up failing over time. And we talk about the pathophys in just a little bit. Same thing with left-sided heart failure, why left-sided heart failure causes right-sided heart failure. So if my left ventricle fails first, let's say due to hypertension, blood is going to back up from my left ventricle into my left atrium and then into my lung. So I'm going to wind up with pulmonary edema. Over time, this pulmonary edema damages the vasculature in my lungs, making it harder for my right ventricle to pump blood into my lungs. So it's, it's almost like fluid. If you just trace back from the left ventricle, you eventually wind up into the right ventricle. And that's why left-sided heart failure usually affects right-sided heart failure eventually. So many patients wind up or have biventricular heart failure or both ventricles due to that cause. So systolic heart failure is when the ventricle loses its ability to eject blood forward. So if we're talking about the left ventricle, the left side is having a problem pumping blood into the body, or we can have systolic heart failure on the right side, which would impair the right ventricle from pumping blood into the lungs. So how does one wind up with systolic heart failure? It can be due to impaired contractile functioning, such as if I had an MI, increased afterload or hypertension. Cardiomyopathy, do a whole chapter on this, but cardiomyopathy is just a term for general overall weakened heart muscle. Or we can have mechanical abnormalities. If my valves are not working properly, this can also lead to heart failure. Our main diagnostic tool for diagnosing systolic heart failure is obtaining an echocardiogram, which gives us the ejection fraction. So our normal ejection fraction is anywhere between 55 and 60%. If you have less than 45%, that's a good, it's a pretty probable thing that you have heart failure. So less than 45% is the diagnosis of heart failure. Some patients have their ejection fraction as low as 10% or less, which is crazy when you think about it. I mean, if I have 150 mLs in my ventricle, if that's my stroke volume, and I'm only pumping 10% of that, that's like dribbles coming out of your ventricle. So you can imagine that those patients are definitely not having their cardiac output needs being met. And at that point, once their ejection fraction gets around 10%, you're on a cardiac transplant list. And in contrast, our diastolic heart failure is impaired ability of the ventricles to relax and fill during diastole. So we have really stiff ventricles, and then our heart cannot fill properly, and that's how blood backs up into either our lungs or our systemic circulation. Because I cannot fill properly, I'm going to have a really low preload, right? I'm going to have a really low volume of blood in my ventricles to be pumped out. So with diastolic heart failure, patients have normal ejection fractions. There's just not a lot in that ventricle to begin with. So using the same scenario, if I have diastolic heart failure and let's say that my normal stroke volume or my normal preload amount is 150 mLs, if I have diastolic heart failure, maybe I'm only filling like 75 mLs. But my ejection fraction, I'm still going to pump out 60% of that 75 mLs. There's just not a lot in there to begin with in the ventricles because it's so stiff. How does one wind up with diastolic heart failure? Hypertension, MI, valve disease, cardiomyopathy. So pretty much the same things here. So we said patients can have either left-sided or right-sided heart failure, or they can have biventricular heart failure where their left and right sides eventually fail. We can also have a mixture between systolic and diastolic heart failure, and that's called mixed heart failure when you have both systolic and diastolic. Most of the time it is seen in more progressive disease states such as a dilated cardiomyopathy, which we have a whole chapter on that. But this can happen with patients who have viruses can wind up with dilated cardiomyopathy, alcohol abuse. And when patients have mixed heart failure, they often have very poor ejection fractions. So what happens in heart failure? Let's go through a little bit of the pathophys. So when my ventricles fail, it leads to low blood pressure, and this is either from inability to pump blood forward, systolic dysfunction, or because I have a really low stroke volume due to my ventricles being unable to relax. They're too stiff, or diastolic heart failure, right? So either one of those leads to low blood pressure, low cardiac output, and poor renal perfusion eventually. I can either have an abrupt onset of heart failure, such as if I had a massive heart attack, a massive MI, and a lot of my ventricle was damaged. I could have an abrupt onset of heart failure. There's also a subtle onset, which happens more with hypertensive progressive diseases, such as coronary artery disease and uncontrolled hypertension. So it happens over time. So when our poor heart can't meet our cardiac output needs, our body tries to help a brother out. So we have compensatory mechanisms in our body that are going to try to maintain our cardiac output. So let's take a look at those, what those compensatory mechanisms are. So first and foremost, my sympathetic nervous system is activated. So when my body senses a decrease in cardiac output, my SNS is activated. And what does my SNS do? Well, it increases our heart rate. It increases our myocardial contractility, right? And it also leads to peripheral vasoconstriction to help get the blood where it needs to go, right, to our vital organs. So I will vasoconstrict to maintain my cardiac output. This sounds great, but all of these, my increased heart rate, increased contractility, and vasoconstriction, all lead to more oxygen consumption of our heart, right? We need more oxygen to pump harder, to increase our contractility. We need more oxygen, more energy if our heart rate's going to increase. So our sympathetic nervous system is initially very helpful in maintaining our cardiac output, but it's also requiring our poor heart that's already not being able to pump adequately to work harder. So this leads to, it actually worsens our ventricular functioning. So that's our sympathetic nervous system. We also have neurohormonal response. This is relating to our RAS system, our RAAS, which is our renin, angiotensin, aldosterone system. When my kidneys sense a decline in cardiac output, my kidneys say, hey, let me help you out because I like to be perfused. So what does RAS do? Well, it eventually leads to peripheral vasoconstriction and sodium and water retention. So my kidneys vasoconstrict, so my sympathetic nervous system is also leading to vasoconstriction. My RAS system from my kidneys is also leading to further vasoconstriction. And then my kidneys are also retaining more sodium and water so I can have an increase in preload. And again, this is all fabulous for maintaining cardiac output, but my poor heart is already so overloaded. So it has an increase in afterload, which is happening with vasoconstriction. And then I also have an increase in preload because I'm increasing the amount of volume by sodium and water retention that's returning to my heart. So my poor heart is having to work so much harder with this neurohormonal response. So again, it works initially, and it's fabulous that we have this, but to a failing heart, it's unable to maintain maintain this. Other things that happens is our pituitary gland secretes antidiuretic hormone, right? And that causes more water retention, which leads to an increase in blood volume, increase in blood returning to my heart, and that's not good eventually. So with ventricular remodeling, my heart is like, oh my goodness, the sympathetic nervous system and neurohormonal response is really making me work super hard. So I am going to have to beef up a little bit and change my shape so I am better able to pump. I want to pump more effectively. So what happens is our myocytes, our actual cardiac muscle cells, change their shape. They get large, and this is initially a good thing, but over time, those myocytes are requiring more energy that our heart doesn't have. And I believe I told you in one of the other PowerPoints that we are beautiful just the way we are, and our heart muscle is most effective when it is pumping with whatever it doesn't want to change. So whenever we change the size and the shape of our heart, whether it's enlargement or the actual cardiac muscle cells themselves, it can lead to dysrhythmias. So ventricular remodeling really places us at risk for dysrhythmias and sudden cardiac death. All right, so that's ventricular remodeling. So over time, and this helps, and then over time it doesn't, like everything else. We have dilation as well. This is enlargement of the cardiac chambers. It's initially effective, but over time this mechanism becomes very inadequate. So with dilation, those muscle fibers are actually stretched to adapt to the fluid volume overload. I think of this as almost like a hair tie for girls who put their hair in ponytails. So when we buy a new hair tie, the things are great, right? I turn it around twice and my ponytail stays so fabulous. But then I keep using this hair tie, I keep stretching it, and over time, that hair tie, now I need to tie it, twist it like 3 or 4 times before it holds my hair in. Why? Because I've stretched it so much that it's unable to recoil or to, snap back into place where it used to be. If you can kind of use that same analogy for dilation, that's what happens. Those muscle fibers are stretched so much, like a rubber band, that they're unable to snap back to where they were. And then we have hypertrophy. So hypertrophy is an increase in muscle mass and cardiac wall thickness. This is something that happens very slowly over time. And unfortunately, our hypertrophied or hypertrophic heart muscle has very poor contractility. So it doesn't contract as well, remember, because we're beautiful just the way that we are. So we're changing the shape of our myocytes, and initially it's helpful, but really over time that does not do my heart any good. And we also require more oxygen the thicker muscle we have. So now our hypertrophied heart muscle is requiring more energy, which our poor heart doesn't have right now. This is just a picture of the dilated and hypertrophied heart chambers. So A is obviously our dilated heart chambers, and then B is the hypertrophied, where that muscle thickness is actually enlarging. Hypertrophy and dilation can occur together. So we can have, and then you wind up with cardiomegaly, you wind up with an enlarged heart, and you can see this via chest x-ray. You'll see that the heart is taking up a huge portion of our chest there. So what does our heart do about this? We have all of this volume coming back to our lungs, and our heart's having to work so hard because I have an increased afterload, increased preload, and my heart's like, oh my goodness, make it stop. So let's continue on. When my heart reaches that point that it's so overloaded and it's really struggling, my heart muscle actually releases these natriuretic peptides called ANP and BNP. Those are proteins that are released from either the atrium or ventricles, And these hormones actually have an effect on counter-regulating our regulatory mechanisms. So this is like my heart's cry for help. So it releases BNP, primarily ANP and BNP. So this is a hormone that takes away, that kind of shuts down my RAS and my SNS system. And in such, it causes diuresis, lowered BP, vasodilation. So we're decreasing our afterload and we're also decreasing our preload. So this is like our heart's cry for help. And what do we test for people who have heart failure is their BNP levels, right? So if it's elevated, if my BNP is elevated, this signifies that I have an increased blood volume returning back to the heart. So my heart is overloaded right now. So like many of the conditions that we're going to talk about, heart failure has acute decompensated heart failure, which obviously are acute instances. And then there's chronic heart failure. So patients who have chronic heart failure can wind up in acute exacerbation. So acute decompensated heart failure is, you can think of it as an exacerbation of heart failure. So how ADHF kind of manifests itself is early on with the failing heart, I have an increase in pulmonary pressures. So I will start to see the patient's respiratory rate increase and then PaO2 decrease. Eventually, because we wind up having such increased pressure in our lungs, we wind up with fluid in our lungs, and then we cannot have appropriate gas exchange. And eventually I wind up with respiratory acidosis because I cannot clear the carbon dioxide from my blood, right? Because there's no gas exchange. This can happen pretty quickly in acute form. So it usually manifests itself as pulmonary edema that we see. ADHF is life-threatening. Patients can wind up extremely acidotic and they wind up drowning. Basically their alveoli are so filled with fluid that there's no gas exchange. So I'm not exhaling carbon dioxide that I need to, and I'm also not able to get oxygen to my tissues. So this is what pulmonary edema looks like. These are some of the clinical manifestations that we will see when somebody has fluid buildup in their lungs. You can read those. I just like to point out a couple. So cough with frothy blood-tinged sputum. Usually it's that pink frothy sputum. And that happens because there's damage to the vasculature in the lungs, and that produces blood-tinged sputum. Crackles, wheezes, or rhonchi can be heard. Usually we'll hear crackles start off in the bases and they'll work their way up towards the apices of the lungs. And depending on the patient's ability to compensate, they can either be hypotensive or hypertensive, and they would be hypertensive from that sympathetic nervous system stimulation, especially that might happen initially. So continuous monitoring for these patients will be done in an ICU or a telemetry setting. Hemodynamic monitoring might be needed if they're unstable, especially an A-line, which would give us continuous blood pressure readings. Supplemental oxygen if they need it, if they are short of breath, or if they have low O2 sats, which are very common with acute decompensated heart failure. And sometimes patients need mechanical ventilation because their lungs are so filled with fluid. Mechanical ventilation can offer some pressure that can help, for lack of a better term, push that fluid out of the lungs. High Fowler's position. And we want patients dangling their legs, even if they have very swollen legs. When they are in an exacerbation, we don't want to increase venous return back to the heart, right? Because their heart is struggling right now. So we do not want to elevate their legs during an acute exacerbation. Furthermore, urinary output is very important to obtain as well. And we do want to keep track of that. So most patients will need a Foley catheter just so we can really balance their intake and output. and to determine if diuretics that we're giving them are working too. Other treatments for more unstable patients include ultrafiltration, or aquapheresis, which is for patients who do not respond well to diuretics, maybe because they're in renal failure. So you can give them all the diuretics you want to, but if their kidneys aren't working, they're not going to void, they're not going to have any output. So ultrafiltration is a way of removing fluid. It's almost like hemodialysis, except you're not filtering the blood, you're clearly just removing some of that fluid. Some patients with extremely low ejection fractions, there's machines to help improve their cardiac output as well, like an intra-aortic balloon pump or ventricular assist devices. We don't get too much into those. And then we also want to treat any anxiety or depression as well, especially anxiety. As you can imagine, if your lungs were filling with fluid, how uncomfortable and anxiety-provoking that must be. Treating anxiety and depression also decreases the risk for non-compliance as well. It is estimated that 50% of patients that have had an acute exacerbation of heart failure will be readmitted within 6 months, again with a heart failure exacerbation. And as heart failure progresses, patients wind up coming into the hospital more frequently to be treated for these exacerbations just because their heart is failing. So compliance is a huge factor in treating anxiety, and depression can help with that. So treatment for ADHF is primarily pharmacological. So we mainly treat ADHF with medications. So our first and foremost is diuretics. Obviously, they decrease our fluid volume overload, so they do decrease our preload, which therefore helps the heart work less. Our diuretics of choice are the loop diuretics, so furosemide and bumetanide, which is Lasix and Bumex. I probably slaughtered that last one. But loop diuretics can be given IV, which is the quickest route, right, to have that have those diuretics work. So that is why we don't have many of the other diuretics listed. Usually it's loop diuretics. So administering these. So we need to be sure that we do not push IV Lasix too fast because it can lead to ototoxicity. So patients can wind up with like ringing in the ears, and they can wind up having hearing loss because of pushing Lasix too fast. It also tanks your blood pressure. So there's some things that we need to be aware of when administering IV Lasix. For example, the potassium level, right? It is an IV form, so patients do diurese pretty rapidly after you get it, and they diurese in large quantities. So instead of a PO that might take a little bit longer, the IV is fast. So we give IV Lasix 10 milligrams a minute. 20 milligrams a minute is the max dose, but 10 milligrams a minute is the safest. So if I were giving 40 milligrams of IV Lasix, if it's 10 milligrams a minute, I would give it over 4 minutes. And then of course I would want to make sure that my patient wasn't really hypotensive because it can drop somebody's blood pressure when giving those. Then we have vasodilators. So vasodilators do several things. They reduce the circulating blood volume, right? They help decrease our afterload, which decreases the workload of the heart. And it also dilates, especially our IV vasodilators, it improves coronary circulation, coronary artery circulation as well. So we're not only vasodilating our periphery, but we're vasodilating our coronary arteries. We do need to watch the blood pressure very closely for either of these drugs. IV nitroglycerin seems to be used, and the nipride seem to be used pretty routinely. The IV vasodilators are only given in critical care units. They are generally not used on any of the floor unless it's like a step down in a larger hospital. Then you might see these. All right, so moving on. Then we have morphine. So morphine reduces our preload and our afterload. It's a mild pulmonary arterial system dilator, and it also mildly dilates our systemic circulation as well. It relieves dyspnea and anxiety, but we really want to make sure that we give morphine in small doses because these patients already can't breathe. So we don't want to depress their respiratory drive that they have. So small doses of morphine. If patients aren't responding, so if patients don't have an improved cardiac output with diuretics, vasodilators, and morphine, we can try a fourth type of medication, inotropic agents, which are listed here. The top two are beta-adrenergic agonist and our milrinone are given IV drip forms, which is great because they act quickly. Digoxin can be given IV, but it's IV push, and it requires a loading dose and then a PO dose to really get therapeutic in our blood system. So generally, the top two are used, and then digoxin is, started more slowly. We want to be careful because giving inotropic, why isn't this first-line medication? Because inotropic agents make the heart beat stronger. And what does it require when our heart beats stronger? Well, it requires oxygen and perfusion, which the heart is really lacking right now. So we do need to be cautious with our inotropic agents. So we covered acute decompensated heart failure, and that can either present very quickly, for example, like we said, if somebody had a heart attack, or it can be something that is happening progressive. So it's really important with chronic heart failure, we still want to treat the underlying cause and contributing factors relating to the heart failure because it's kind of like our CAD patient. So heart failure can be present and changes are going on in the heart, like some of those remodeling things that we talked about before, but they don't have any symptoms yet. So we do want to really make sure that we're treating the underlying cause, for example, like hypertension, controlling diabetes, quit smoking, those sorts of things. So the symptoms that patients will get with chronic heart failure are really dependent on age, the underlying type and extent of the heart disease, and the type of heart failure which they have. So is it a diastolic problem, a systolic problem? Is it the left ventricle, the right ventricle? Is it biventricular? And what's going on in the heart, or what caused this heart failure? So the Heart Failure Society of America developed an acronym, FACES. So as you can see, they are symptoms that we can help educate patients on that will help them identify symptoms of heart failure. Fatigue is one of the earliest symptoms of heart failure or worsening heart failure, or maybe progression into an exacerbation of heart failure is fatigue. But fatigue is so vague that many patients don't recognize this. So this slide really outlines some of our treatment goals, which we went through before, but we will go through treatment for chronic heart failure, more signs and symptoms, and whatnot, but you can read through this slide. Some of the other symptoms that will be present in patients with chronic heart failure, we said fatigue, dyspnea, orthopnea, which is the inability to lay flat. So we would ask patients how many pillows they sleep with, or have you noticed that you're sleeping in a recliner, so the head of the bed has to be up. Paroxysmal nocturnal dyspnea is sudden awakening at night related to shortness of breath. Tachycardia, skin changes, especially pale, right, because we're not getting the perfusion. Behavioral changes would be sudden changes in maybe forgetfulness or sleepiness, being very tired because of lack of perfusion to the brain, chest pain and weight changes as well. Weight changes can either be loss of weight because of that increased buildup in our GI tract. That fluid can make us not be hungry, so patients can actually lose weight, Or if they have a lot of fluid retention, they can gain a lot of weight. So that's why it's weight changes. It's very dependent on the person and what's going on. Chronic heart failure may or may not be treated with oxygen therapy because it can relieve dyspnea, relieve fatigue, and obviously we know that we're having a problem with the amount of circulating oxygen, especially with our left-sided heart failure because our lungs are filling up with fluid. Physical and emotional rest, just to conserve energy needs. Structured exercise programs are also needed for patients. Why? Because exercise actually can improve the function of our left ventricle. But it does need to be a structured exercise program because we want to make sure that patients aren't overdoing it. And we also want to make sure that they have the education they need to get the full benefits of exercise. Biventricular pacing, or that CRT therapy that we talked about, this is a pacer if our ventricles are not pumping at the same time due to enlargement or hypertrophy. They can have a biventricular pacer that will help the ventricles pump simultaneously to maximize our cardiac output. Many times these have an ICD in place because if our ejection fraction gets below 35%, we're at more risk for ventricular dysrhythmias. And especially with our ventricular remodeling or dilation and hypertrophy that are happening, or that could happen with heart failure, that do happen with heart failure, we're altering the shape and size of our cardiac myocytes, our cardiac muscle cells, and that also leads to increased risk for ventricular dysrhythmias when we change or alter the shape of the heart in any way. So other treatments for chronic heart failure is diuretics, to obviously reduce the edema, reduce preload, leading to fluid loss, right? The diuretics that can be used can either be loop diuretics, thiazide diuretics. We just need to be sure that we check patients' potassium levels because both of those are K-excreting diuretics. And then we have our RAS inhibitors. So the RAS system was one of the compensatory mechanisms that the body initiated when we have an exacerbation of heart failure. And we know that this can lead to, the RAS system can lead to holding on to more fluid and also increasing blood pressure. So we have RAS inhibitors to go against that. And one of those is ACE inhibitors, which are our prils, such as lisinopril or captopril. So these medications actually work by decreasing afterload, and they also help prevent against that ventricular remodeling, that hypertrophy that can happen if the heart's having to work really hard to pump out blood, which is a good thing. One of the most common side effects for ACE inhibitors is a dry, non-productive cough, which can be very irritating to patients. It is fairly common. And if that occurs, patients may be switched to ARBs, which are the angiotensin II receptor blockers. They work in just about the same way as ACE inhibitors do, but they don't have that side effect of the dry, non-productive cough. So ARBs are generally used if patients show intolerance to ACE inhibitors. And then we have our aldosterone antagonist, which is also a RAS inhibitor, such as spironolactone, which is a diuretic. Spironolactone holds on to potassium, so we need to monitor potassium levels because they are at risk for hyperkalemia because spironolactone is K-sparing. So our other medications for chronic heart failure that can be used are beta blockers, so our LOLs, right, LOL, and these work by blocking our sympathetic nervous system and the effects of that because our sympathetic nervous system leads to an increased demand on the heart, which our failing heart can't handle. So you may also notice that in your pharmacology book and in many of the drug books that a contraindication or a caution is to use beta blockers cautiously with heart failure. Well, then why are we listing it? It's because if I were taking a beta blocker and I went into, let's say, a flash pulmonary edema or, an acute onset of heart failure, the thing that's saving my butt is my sympathetic nervous system. So if I am blocking that because I'm on a beta blocker, it can lead to a more increased decline because I don't have that initial sympathetic nervous system response that I need to control or maintain my cardiac output. The other thing we want to be careful with is educating patients not to abruptly stop their beta blockers. And then we have our vasodilators, which are our nitrates, which help by dilating the coronary arteries, which allows for increased perfusion to our myocardium, which is always a good thing, right? And then we have our positive ionotropic agents, such as digoxin or digitalis. Digoxin has negative chronotropic effects, right? Decreases heart rate, and it also has positive ionotropic effects. The thing with digoxin is we need to ensure that patients have a therapeutic digoxin level. So the therapeutic level for digoxin is 0.5 to 2. Potassium directly affects whether or not somebody could be more prone to digoxin toxicity. So when somebody is hypokalemic, they have an increased risk for digoxin toxicity. And conversely, if you have hyperkalemia, it's going to decrease the efficacy of that digoxin. So what are some of our digoxin toxicity symptoms? Bradycardia. We never give digoxin for a heart rate less than 60 for our adult clients. And if we do, it can cause further bradycardia, right? Other signs and symptoms, nausea, vomiting, and diarrhea. It can cause weakness, changes in vision. It can either cause blurred vision, or you might see colored halos, like yellow halos or orange halos around bright lights. That is a sign of digoxin toxicity as well. Especially in our older patients, confusion and headache, even as far as hallucinations, can be also signs, especially more so in our elderly clientele. So besides medications, it's very important for patients to follow a low sodium diet, a DASH diet, and this is to help decrease the afterload. Sodium is usually restricted to about 2 grams a day, which is great, but what does that mean? What is 2 grams a day? So 1 teaspoon of salt is equal to about 2,300 milligrams, right? Or 2.3 grams a day, if you want to do the math, which took me a minute. So if you add a lot of salt to your diet, you're probably adding an extra 2 grams a day just by sprinkling it on food. I was looking it up, and some, like the average American or patients who are using salt in their diet eat about 7 to 8 grams a day of salt, which is very unhealthy. But it's not something that patients or people usually monitor, right? We look into calories and carbs and sugar and all of that other stuff, but salt is also very important, especially in heart failure. In our more severe end stage patients with chronic heart failure, they may be on a fluid restriction. Generally, it's less than 2 liters a day. If they do require that they be on a fluid restriction to help decrease the edema. I have here ice chips, gum, hard candy, and ice pops. Sorry about that. So we need to make sure that if we do instruct patients that they can have ice pops or ice chips, that they still count toward that 2 liters a day. There was a patient who was told that if he was really thirsty, just to have ice chips throughout the day, and he wound up having, eating ice chips literally all day long and was not using that intake to account for his 2 liters a day. And he wound up in obviously fluid volume overload and came into the hospital. So just something to tell your patients that they can't be having it all day, and it still accounts for their fluid intake. Daily weights is also very important. They need to be done every morning, same time, same scale, in your birthday suit. And patients should be documenting this or writing it down in some sort of a journal or on a calendar. That way they can track it. So weight gain of 3 pounds over 2 days or 5 pounds in a week should be reported to the healthcare provider. So some of our assessments that we will make on our patients. So fatigue, since that's one of our earliest symptoms, depression and anxiety, that can happen because of the heart failure and the inability to do activities that they once were able to do. Their usual sodium intake. So most patients don't know how much sodium they intake. So a better idea to gather how much sodium is to asking about the foods that they are eating. And then we can gather if that is high in sodium or not. So foods that are high in sodium, anything that's smoked or cured, meats, very high in sodium. Anything obviously with salted added to it, such as chips, baking salts, so like celery salt or onion salt. It's better to get the powders. Let's see, anything that's frozen breads, frozen meals, a lot of frozen things have sodium because that's what we use for preservatives. Soups and salad dressings also have high sodium intake. Assessing for nausea, vomiting, anorexia, or feeling full and lack of appetite. Stomach bloating, weight gain, ankle swelling. So we would ask to see their weight charts if they have them, or ask about their normal weight, and then kind of get it from there. Other subjective data that we should gather as well: dyspnea, orthopnea, cough, assessing if patients have any palpitations, making sure that they are taking their medications appropriately, and asking if they're on any over-the-counter meds that they're taking regularly or any herbs and supplements, because those can interact with the medications that they're on. Number of pillows that they use for sleeping at night. That would give us an indication about orthopnea. Do they have PND, which is the paroxysmal nocturnal dyspnea, the sudden awakening at night with shortness of breath? So just to add to our subjective list. And then our objective, so things that we would observe, their skin color. Are they pale? Are they clammy to the touch, or are they warm and dry and pink? Edema we would assess for. Respiratory rate that we would count accurately, right? We just don't go in and guess a number because that's what we think. Respiratory rate needs to be counted accurately. And breath sounds. Normally, for patients who may have fluid in their lungs, we would hear crackles that start at the bases, and then that as the fluid increased in their lungs, or as the pulmonary edema increased, those crackles would be heard further up in the lungs. Frothy blood-tinged sputum. If we do see that, that's an indication of our acute pulmonary edema because of the damage to the pulmonary vasculature in the lungs with the increase in fluid volume. Heart rate and sounds, we would expect that patients who are, might have more of a difficulty or an exacerbation would have an increased heart rate. But depending on the medications that they're on, if they're severely beta blocked or, on digoxin and some other medications, that might not be as high as we would think. And then heart sounds, we can hear extra heart sounds such as S3 with fluid volume overload, abdominal distension, and changes in level of consciousness, fatigue as one of our earlier symptoms, forgetfulness, restlessness is very big as well. So just keeping an eye on the whole body system, not just listening to the heart. Continuing on with our objective data, getting our serum electrolytes, especially potassium, magnesium, sodium levels, checking our kidney function. in our LFTs, because if we do have an increase in fluid, that can affect our liver function tests. And we also want to make sure that the kidneys are working appropriately to allow for diuresing. Checking a BNP, or some hospitals have NT-proBNPs, which is the same thing as a BNP, it's just more specific. So numbers will be higher, but if our BNPs are elevated, that would make us think that there's too much volume going back to our ventricles, and that's what is released, is that hormone BNP. Chest x-ray, we would be able to see if there's any cardiomegaly, any pulmonary congestion, or pulmonary edema. Our echoes to gather our EF, or we might be able to see if there's any heart wall abnormalities, if there's hypokinesis. ECGs, and obviously our O2 saturations as well. ABGs might be something that we would have to gather, need to gather, because we would expect patients to have respiratory acidosis with heart failure if they are coming in an exacerbation, not for chronic heart failure, but exacerbations, because they're unable to have normal gas exchange with the fluid buildup in their lungs. So since heart failure can be caused by many different things, it can either be a progressive disease, or it can be something that happens fairly suddenly, especially after an MI, or if somebody has issues with their valves. So really determining and treating the underlying cause can help manage our heart failure and the symptoms that are associated with them. An endomyocardial biopsy would be done in somebody who has heart failure and we're unable to determine the cause. For example, cardiomyopathies, sometimes we don't know why somebody has a cardiomyopathy or an overall weakened heart muscle. So we can obtain a biopsy of the myocardium, send that off, and sometimes that can give us answers. Echoes or nuclear imaging can, have us paint the bigger picture, get a better look. Chest x-ray, ECGs and stress tests, cardiac caths, and then our BNPs or ABGs, which we covered. For our interventions, monitoring the respiratory status. So this would include pulse oximetry, respiratory rate, the effort of their respirations, auscultating breath sounds to see if there's any pulmonary edema, or to monitor the effectiveness of our treatment. Do they have a decrease in crackles? Monitoring for restlessness and anxiety. That would make us think that maybe somebody is leaning toward hypoxia. Administering oxygen therapy, either nasal cannula, or many times if patients come in with pulmonary edema, they might be placed on BiPAP, because that extra pressure that BiPAP has can help move the fluid out of the lung tissue. Semi-Fowler's position, at least, or to increase the head of the bed, wherever the patient is comfortable, but we do not want them lying flat. Monitoring their hemodynamic status, which includes edema, peripheral pulses, cardiac output, their heart sounds, their kidney function, how well are they voiding? So their I's and O's would be part of their hemodynamic status. And then, because medications are really a big part of managing heart failure, administering prescribed medications, and also making sure that we educate patients regarding those medications to ensure compliance. So reinforcement, so heart failure is a progressive disease, so we really want to establish good treatment plans and quality of life goals. Unfortunately, as heart failure does progress, there's going to be more frequent admissions, and it's really important that we discuss end-of-life goals or quality of life goals, and really involve the family and caregivers in this plan. Using self-management tools for symptom management. You will find one of those self-management tools under the course, and it's just a form that patients can place on their refrigerator, and it gives us a list, or gives them a list of symptoms that they should watch out for. So it's just kind of an idea to say, hey, if if you have weight gain, even though it might seem silly to you, even if it's only 2 pounds or 3 pounds, if it's over 2 days, 3 pounds over 2 days, then you need to call somebody. So it's just for, extra reinforcement right there where they can see it. Restricting salt, and then being on a fluid restriction, at times if they need to be. Conserving energy. So while somebody is exercising, to make sure that they take frequent breaks, frequent rest periods. And this is why sending somebody to cardiac rehab is very important as well, so they can learn how to conserve their energy but still have activity, right? Because exercise can actually strengthen the ventricular functioning. It can help our ventricles work better and increase our ejection fraction. So exercise is very important. And then maintaining support systems, really making sure that we include caregivers and families in the plan of care. So this slide is just reinforcement of what we talked about, so I'm not going to read it to you, but please read this over. So some complications that we may see from heart failure, these include pleural effusions, and that's due to the increase in pulmonary pressures. So we can get fluid displaced, and then, pleural effusions is fluid buildup within the pleural space, and then that does decrease the amount that our lungs can take in, the amount of oxygen that our lungs can take in. We discussed pleural effusions, in a later chapter. Dysrhythmias, so dysrhythmias can be caused because heart failure can alter the shape and size of both our atria and ventricles. So we are at risk for many different types of dysrhythmias. Left ventricular thrombus, this can happen because of an enlarged left ventricle and our decrease in cardiac output. So we have more blood stagnation. Our blood is just kind of hanging out in our ventricles. So we have this enlarged chamber, and we also have this chamber that is not pumping effectively. So we get blood stasis, which can lead to a thrombus. And we can have hepatomegaly, which is caused from the fluid buildup in our abdomen from right-sided heart failure. And then renal failure. Renal failure, unfortunately, is very common with heart failure, especially advanced heart failure, because we have heart failure when you have heart failure, you're not maintaining a good cardiac output. And our kidneys are, unfortunately, one of the organs that is not being perfused that well, and that can lead to heart failure. They call it cardiorenal syndrome. Because it happens so frequently that patients with heart problems also wind up with renal problems because of the decreased perfusion. So cardiac transplant can be treatment of choice for patients with end-stage heart failure, or especially in our cardiomyopathy patients because they can be fairly young. There was a patient that I took care of who was in their young 20s and actually had cardiomyopathy due to Epstein-Barr virus. So that was very sad, but his EF was less than 10%, and he was on a transplant list. Obviously, there's a very strict selection criteria, but that's pretty much all we're going to get into as far as this, is just knowing that cardiac transplant is an option for patients.